From a practical and pathophysiological point of view, we can divide the wall motion abnormality in 5 categories. First, when we have wall thickening abnormality. This type of the wall motion abnormality is because of the ischemia or coronary artery disease, and the myocardium cannot be thickening very well that we are going to talk in this presentation. The second group are those cases that we don't have a serious and significant coronary artery disease and contraction of the myocardium, and in other words, thickening of the myocardium in all wall are normal, but the pattern of contraction is not normal, that we can detect it in strain echocardiography. Like those systemic disease, at top of them we can name cardiomyopathy like amyloidosis, sarcoidosis, or left ventricular hypertrophy or hypertension, and so on. In those cases, even at least at the beginning of the disease, we don't have coronary artery disease, ejection fraction looks normal, and we don't have problem in thickening of the myocardium, but we have some abnormal pattern of contraction that we can detect in by strain echocardiography, as I show in this bull's eye pattern of a patient with beginning of the amyloidosis. And I'm going to talk about all this pattern and abnormality in different lecture. The third group are those that we have significant and important electrical abnormality, like worse Parkinson-White, Burgado syndrome, or left bundle branch Brach. As we know, the way left ventricular contract, twisting and squeezing in a very smooth and specific pattern, dependent of the way electrical activity firing, the order of it. And we know first the septum starts, then it goes to the apex, and finally basal of the heart fire and contract. Whenever we have this order of the firing and the polarization of the myocardium change, some wall not coordinate with the other. So we will have some kind of discrepancy and dysynchrony of the walls. And this is another topic that we are not going to talk about this today. The fourth group are related to the right ventricular wall motion abnormality. Besides of the infarction of right ventricular that's dependent of the right coronary artery, we have some specific situation that it causes a specific pattern of wall motion abnormality in right ventricular, like the pulmonary embolism or pulmonary hypertension. And again, this is another topic for another lecture. And the last one is physiologic wall motion abnormality. The reason I called it physiologic because the shape of the heart dependent of the all structure around and the all forces around the heart. That causes the shape of the heart cone shape that we have it in normal situation. But whenever those pressure and forces change, the shape of the heart and movement during systole and diastole will be changed, and it looks like abnormal. Like whenever we have intra-abdominal pressure increased, for example, pregnancy or hepatomegaly, or huge and severe ascites, or other way in thoracic pressure, like when we have pneumothorax. So in those cases, we may have nothing, have any specific pathology on the heart, but the wall motion looks like abnormal. Now let's see talk about wall motion abnormality due to ischemia. As we know, heart is supplied by two main coronary artery, right coronary artery or RCA and left coronary artery, LCA. Left coronary artery divided to the two main branches, circumflex and left anterior descending or LAD artery. Whenever we have ischemia, the wall motion and that myocardium that involved with this related artery become ischemic and cannot contract very well. The most common places for blockage or obstruction of coronary artery has been shown in this picture by black circles. But any spot of the coronary can be involved in atherosclerosis and embolism or any process that we have in coronary syndrome. Left ventricular will supply by all these three arteries, right? RCA, LAD, and circumflex. The territory of those three vessels are very specific and distinguished. So, based on this territory, left ventricular wall divided almost to 6 equal walls. The landmark for these walls are intersection of the right ventricular, the point of the joining of right ventricular to the left ventricular, and papillary muscle. In this way, the distance between the two interjection of the right ventricular to left ventricular will be interventricular septum that can be divided to almost 2 equal. One, the top or anterior, we called it anteroseptal, or sometimes they called it IVS, and the below one is inferoseptal, or sometimes we called it septal wall. The other 4 walls are almost equal, and the landmark for those is papillary muscle, tip or base of the papillary muscle. So we will have 4 extra 4 walls: anterior, anterolateral, or sometimes we call it lateral. Many times actually they call it lateral, anterolateral, inferolateral. Most of the time they called it posterior, and inferior walls. The reason I am going to call all those two names for these 4 walls is because each cardiologist, they use and prefer one of them. So I want you to get used to both of those names. So we have anteroseptal or IVS, inferoseptal wall, inferior, inferolateral or posterior, anterolateral or lateral, and anterior walls. Now let's see how we see those walls in which view, each of them. First, we go for the plaques. On the plaques, our cross-section plane passed through this line. Apical tree and plaques are, both of them are the same, just orientation and apex is more clear. So we have apical tree and plaques. In the plaques or apical tree, the marker is this side, opposite way, the other wall. So the one wall is closed or side of the marker here, or this one, will be anteroseptal or IVS. The other wall, that far, is posterior or inferolateral wall. So anteroseptal and inferolateral wall. Anteroseptal or IVS, and posterior or inferolateral wall. For in apical 4, as we have here, the cross section of the heart will be on this line. So our sector plate passed through the inferoseptal and anterolateral or lateral. Since our marker is to the right side here too, and on the body is right side. So this wall, this wall is anterolateral or lateral wall, and this one is septal or inferoseptal wall. And the last walls are anterior and inferior that we can see in apical two-chamber view. As you know, here our marker is toward this side. So the wall that close to the side of the marker is here. This one will be anterior wall, and the other one will be inferior wall. Here, as you know, the left ventricular shape is cone shape. So at the base of the heart, the width of each wall is more than the width of the wall at the apical side, apical point. In another word, in base of the heart and the middle of the heart, left ventricular has divided to 6 walls, but at the apical divided to 4 walls. So in the apical section, if we go short axis, that shortly I am going to talk about that, anterior septal and inferior septal become 1 wall, and anterior lateral and inferior lateral become 1 wall. To this, at the level of apical, we call it lateral, and this one we call it septal. So at the apical level, we have only 4 walls: septal, anterior, inferior, and lateral. Each of the wall has a specific pattern of the blood perfusion. In other words, each wall supplied by 3 major branches of related coronary artery. So each wall divided to 3 segments. One of them 3 almost equal segments. The one that is close to the base of the heart, 1/3, we call it basal segment. The middle one we call it mid segment, and the top one or close to the apex we called it apical. So each wall divided to the 3 segments again: basal, mid, apical, basal, mid, apical. It is the same, so on, all of them. And but in the short axis, how we can see and detect those segment and wall in short axis? Here again we have short axis of the heart at the level of the tip of the papillary muscle or fish mouth, on the tip of fish mouth view. We have at the basal again the same. Here intersection of the right ventricular and left ventricular will be our interventricular septum, and we can divide it to 2. So we have from here, intersection here to the mid is anteroseptal, and from middle to the intersection is inferoseptal or septal wall. From there to the papillary muscle, anteromedial papillary, anterolateral papillary muscle, we have anterior. Here to here we have anterolateral, and here we have between 2 papillary muscle, most of it is inferolateral or posterior, and the next to the posteromedial papillary muscle we have inferior wall. So one more time: anteroseptal, inferoseptal, inferior, inferolateral or posterior, anterolateral or lateral, and anterior wall. This is at the base of the heart. and our landmark is the tip of the mitral valve. The reason I brought here in this image that is not tip of the valve, a little past, and see, you can see some chorda tendini and bifurcation of this papillary muscle to tip of the papillary muscle. There is a reason I brought it because of the contrast study. Shortly I am going to talk about that. The landmark for the mid segments are the insertion of the papillary muscle, and then again we divided with those landmarks into 6 walls. Here we have mid view of the left ventricular. Again, we have intersection of the right ventricular to the left ventricular. So this from here to here will be interventricular septum, half part anterior, this is anteroseptal, and half below is inferoseptal, or septal and IVS. IVS or anteroseptal and septal or inferoseptal wall. Here we have papillary muscle posteromedial, so we have this one from here to here is inferior wall. Between these two papillary muscle will be inferolateral wall or posterior wall. Here we have at the papillary anterolateral papillary muscle, we have anterolateral wall and segment, and finally we have anterior segment or anterior wall. And the last region is apical segments. Apical segment, as you see, when we pass, based on the orientation of the heart, we fan it more to the apex or slide the probe to the apex. We pass insertion of the papillary muscle. We don't see papillary muscle anymore, just intersection of the right ventricular to the left ventricular. That will be our apical view for apical segments. Here again, we name it here. We have right ventricular, this spot and this spot are intersection and joining the right ventricular to the left ventricular. So this will be septal wall. Opposite way, this part will be lateral wall. This one will be anterior, and this final is inferior. So septal, anterior, posterior or lateral more accurate, and inferior wall. Now let's go why I brought it this one. As I said, the basal landmark for basal view is a fishhook of mouth, the tip of the mitral valve. But when we do contrast study, because of hyperechogenicity of the contrast material, we cannot see mitral valve. So since in most patients they have a long papillary muscle, and tip of the papillary muscle in those cases is almost close to the tip of the mitral valve, so we can use the tip of the papillary muscle as a landmark for basal view when we do contrast study. And our landmark that we are in right spot, that the papillary muscle doesn't connect to the myocardium at both sides. Even in this case, the anterolateral papillary tip of the papillary muscle is to bifurcation, but doesn't contact with the wall. So we can see a happy or smiley face. They called it happy or smile face view. That we can know that this is basal view of the heart. In those cases, they have very short papillary muscle, and we don't see this free papillary muscle inside of the left ventricular. We fan or slide toward the apex until we will see papillary muscle show up. When we saw papillary muscle, connection of papillary muscle to wall, then we slide or angling toward the base of the heart, then that will be our basal view for segments. Now, let's see which of those walls supplied by which of those coronary artery. As a general rules, but not 100%, as general rules means majority of the cases, over 90%, anteroseptal and anterior wall supplied by LAD, left anterior descending coronary artery. So in apical 3 or plaques, anteroseptal and in apical 2 anterior wall supplied by LAD. Anterolateral in apical 4-chamber view that we see in the apical 4-chamber view in long axis supplied by circumflex, and basal septal or inferoseptal, basal inferoseptal and basal inferior, and almost most of the time, over 85%, mid inferior segment supplied by right coronary artery. That is general rules. How we name those segments? For naming those segments, we use first the location of the segment, then we add a name of the wall. For example, here we have, this is basal and belong to the anteroseptal, so we called it basal anteroseptal segment. Here is mid, we called it mid anteroseptal. Or this one, for example, is anterolateral and mid segment, so we called it mid anterolateral segment. Or this one, apical anterolateral segment, and so on. For reporting of those segments, we usually use bullseye pattern and method. In this method, we divided the circular shape to 3 parts, and one last one. I am going to talk about this last one. The outer represent the basal part, the middle is mid segment, and the inner one is apical region. American Heart Association take as the tip of the apex or cap of the apex as a separate segment. So instead of the 16 segment, we will have 17 segments. And in all those functional imaging study and strain echo, the bullseye pattern divided to 17 segments. The numbering of each segment is, we start with the base and anterior segment, basal anterior wall. We give number 1 and we go counterclockwise and we add 1 number to each of them, all the end. For example, this one is mid and this is anterior, so is mid anterior segment, or so on, all of them. With a little practice and look at them, you can see and name those segments. Here there is a pattern of the blood perfusion. Again, LAD supply to anterior and anteroseptal, RCA supply to inferoseptal and inferior, and circumflex to the anterolateral and inferolateral, anterolateral and inferolateral or posterior. But if we go more accurate, we will see a little differences. The only segment that is specified for a branch of those artery, coronary artery, is these segments that 100% supplied by LAD. The other here, for example, LCA, in 98% supply anterolateral at the base, basal anterolateral, and 95% inferolateral at the base. And if you go to the apex, the percentage decreased, and also on. So in another word, except those basal for each of those three branches, the mid segment usually, except the anterior and anteroseptal, usually supplied by more than one, or there are a lot of variants of blood perfusion that which of those arteries supply those segments. Here is a difference pattern diffusion by proposal the American Heart Association, and a study on 100 patients with the myocardial infarction by contrast cardiac magnetic resonance imaging. They are very close, almost is the same. So anterior or anteroseptal by LAD, inferoseptal and inferior by RCA or right coronary artery, and anterolateral and inferolateral by circumflex. Here is another schematic for this distribution of the blood supply in each of those segments that you can study by yourself later. Now let's see how we evaluate wall thickening abnormality. As like the other muscle, when myocardium contract, the length becomes short, but the width become thicker. So the thickness increased in myocardial contraction. How we can evaluate this thickening? We have two techniques. One way is we go find the endocardium and see how much endocardium during contraction or systolic phase move inward, toward inward. That technique was used by color kinesis before, but nowadays we don't use it. But in some way, in strain echo, we use this concept, but we don't use just this endocardial excursion or moving inside. The best way is measuring myocardial thickening, how much the myocardium become thick during systolic phase. For measuring myocardial thickness, we have three techniques. One is M mode, another is 2D, and the last one is by eyeball and guessing. If the M mode do correctly, is very accurate and reliable in our measurement. And the most important criteria for doing M modes for wall thickening measurement is that our cursor be perpendicular to that wall we are going to evaluate and measure wall thickness. Fortunately, nowadays all the machine give you this option that you can move and rotate your cursor around and make it completely perpendicular to the wall, and then we can measure at the end diastole and on its end systolic phase. If we, for any reason, we cannot use M mode, we can do on 2D. We go with the frame and cine loop, find the end diastolic and then end systolic, and measure in those two spots. Or we go and evaluate the wall thickening by eyeball and guessing. That you are going to talk in next slides. The movement of for the movement of myocardium, we use a definition of kinesis. Kinesis means movement. And the pattern of this movement and thickening has different definition. First, we have normokinesis. Normokinesis is when the myocardium thicken more than 30%. For example, if at the end-diastole our myocardium we measure 8 millimeter and end systole it becomes 12, so it is more than 30% increase the thickness. So it is normokinesis because 30% of the 8 is 2.4, so 2.4 plus 8 become 10.4. So 11 millimeter will be normokinesis. Or if we use the color kinesis, the amount of the endocardial excursion is when more than equal or more than 5 millimeter endocardium move inward. We call it normokinesis, but we don't use endocardial excursion measurement for our evaluation. If the thickness is less than 30%, we called it hypokinesis. Hypokinesis, the thickness here, for example, is normal, is more than 30. This one, a little than the other side, or less than 30%. Some cardiologists use when the thickening is less than 20%, between 10% or to 20% increase, they prefer call it severe hypokinesis. The next term is akinesis. Akinesis when is the myocardium during systole, it doesn't change at all. So whatever it is on the diastole, at the systole stay the same. We call it akinesis. Akinesis is when less than 10% increased. So it can be not increasing or less than 10%. We called it akinesis. Dyskinesis is when the involved segment, affected segment during systole bulge outside or become thinner. So it becomes thinner during diastole. For example, if during diastole will be this amount and then become less, we called it dyskinesis or bulging outside, any of them. And the last one in this category, we have aneurysmal movement. Aneurysm is when that affected segment always bulging out during diastole and systole is bulging outside. We called it aneurysmal. The next term is hyperkinesis. Hyperkinesis usually we will see when one segment is hypo or akinetic, but the next segment, adjacent segment, will be hyperkinetic because you know all segments they pull each other during systole, pulling each other. When one segment become hypo or akinetic, so that opposite force disappear, so the adjacent segment show and become more kinetic or hypokinetic. Another term is tardokinesis. Tardokinesis is when a segment contract a little later compared to the other segments, or tard means delay. Tardokinesis when there is a delay in maximum contraction. And the last one is irrelaxation. Irrelaxation usually when we have bundle branch block, we have this type of the irrelaxation because in bundle branch block the duration of the polarization of the myocardium septum and all left and right become longer, so the early spot that has polarized become depolarized. So it looks like at the some part are at the maximum contraction, some part are in relaxation. Those two can be detected by checking frame by frame, and we go back and forth and see if that segment has delay or relaxation or not, or we can use it, we can detect these two abnormal movement by strain echo, as you will see in this case at the basal inferior wall has contraction a little delay compared to the other segments. That I'm going to talk about this type of study in another lecture. Now let's see how we check wall motion abnormality during ischemia or due to ischemia. First of all, we have to keep in our mind those non-ischemic cases of wall motion abnormality. That's at the beginning of the presentation I talk about them. Then we go check these factors. First, echogenicity of each of those segments. Second, we evaluate and check each segment separately. Third, we compare them with each other. Fourth, we look at not only movement of the segment. That is not important. The most important part is how much endocardium, if the endocardium move inward and the myocardium become thick or not just movement of the segment, because even when we have akinesia or hypokinesia, other segment that they have normal activity, they can move that segment and pulling those segment and give impression that the affected segment move too, but really it doesn't contract and we don't have thickening. Don't confuse movement and thickening. Then if we have any abnormal finding, we have to try to show in another view if we have for that segment. And finally, we have to looking for other accompanying finding that usually is with those ischemic process. Now let's go one by one. The first step in evaluation of wall motion is getting the right and correct image. Make sure that you don't have off axis or foreshortening, especially in apical view, and in short axis make sure you are perpendicular. Image is perpendicular at that level, not oblique. That I talk in very detail in another lecture. You can check it out. After making sure that we have right image, we have to optimize it. As a general rule, a noisy and dirty image that has clear endocardium is better than a nice and clean and black and white image that doesn't have a clear endocardium. So in other words, my recommendation to you is when you are evaluation for wall motion, always increase gain until you see at least endocardium clearly. Second, as usual, we scan by grayscale, but when we change the color, our eyes and brain become more sensitive and detail oriented when we change the color. So as a general rule, when you do getting shot for wall motion, zoom in the left ventricular in apical, for that subject, change the color to any color, magenta, violet, or red, or whatever, that your eye is more sensitive and can pick it up the endocardium very well. After optimizing image and changing the color, then we go by using our hand or paper, we select and check each segment separately. For example, in this case, we go one by one, each of them, and see if there is any abnormal thickening wall or not. Here, I use this one and cover. As you notice, the apex here, apex even move up and down a little. The movement is pulling by the heart, not the contraction of the myocardium. If you notice, during systole and diastole, myocardium doesn't contract and doesn't become thick. So we have high on echo here up to here, on echo apex, but here a little, if we move there, we will have a little at the apical side. This is septal apical. We have a little thickening, we call severe hypokinetic. And so each segment we check it separately by covering a paper, putting a paper or hand, and then we compare each segment with the next or other segments. Here, for example, this segment, it looks like normokinetic very well, and this segment compared to this segment, these two are normokinetic. But if you look at this segment with compare and next segment, this one, so this is hypokinetic or severe hypokinetic. So it's mid and apical, and mid segment and apical segment, and apex and anterolateral and mid septal, they are severe hypokinetic, and here almost maybe we can call it akinetic. But the basal, anterolateral, and basal septal or inferoseptal are normokinetic. As we say, always look at the echogenicity of the wall. For that, if you need it, optimize your image, decrease gain or increase gain until you have good optimizing, and compare those segments with each other and see which segment has echogenicity change. For example, as we know, the sigmoid shape and the mid segment and sigmoid of the interventricular septum is usually hyperecho. Any hyperechogenicity in other segment, you have to be suspicious. Here, we have hyperecho at the mid segment of anteroseptal wall. And not only hyperecho, is thin and doesn't move through at all. So is akinetic, thin, is akinetic and thin. Akinetic, hyperecho, and thin indicate necrosis and scar tissue. When you saw something, for example, the previous slide, it was mid-septal, anteroseptal akinetic. So we have to confirm that one in short axis. Here we have the same patient, short axis. As you notice, this inferoseptal, inferior, inferolateral, lateral, and almost anterior wall are normokinetic, but anteroseptal we don't see it very clear, so we don't name it. But here, anteroseptal is hyperecho, thin, and doesn't thick at all. So we confirm that segment in short axis too. Whenever we have severe ischemic disease, and in this case, for example, mid-anteroseptal akinesis, so Always in those severe cases, usually we have other finding like TR functional MR, or even pericardial effusion if it's acute or subacute infarction, myocardial infarction. Always look at to the other finding that's related to that finding. It can be complication of that, or like the rupture or pericardial effusion, hematoma, or anything. Always look at the other finding that you may be find. Now see another case. Here we have apical four-chamber view. Again, we go one by one. We check anterolateral wall. Here we have very nice and good, actually hyperkinetic basal anterolateral, mid anterolateral, apical anterolateral, and apex and apical too, up to here. But if we continue, we will see at the mid and inferoseptal or septal, mid septal or mid inferoseptal, not only doesn't move, doesn't become thick, is moving if because the other part of the heart is moving this segment a little this way, but during systole, if you notice, it becomes thinner. So we have this kinesis at the mid inferoseptal segment. Here we have basal inferoseptal or septal that is almost normokinetic. If you look at compare this segment to other, the other part of the heart is hyperkinetic, and this segment is dyskinetic, thin and bulging during, become thinner and bulging during systole. Next, see, and if we change the color, maybe your eyes become more sensitive and you can pick it up, those changes, differences easier. Many times when you do valve motion, especially in apical 4 and apical 2, when you do Simpson, if you have abnormality, you can see it at the when you do measuring ejection fraction by Simpson. For example, that previous patient had mid inferoseptal. Here is bulging at the end diastole, and you will notice that abnormality. Here we have apical two-chamber view. We have anterior wall and inferior wall. Again, we go one by one. Basal, mid, and anterior and apex move very well and even hyperkinetic. They are hyperkinetic. But mid-inferior segment is akinetic and more accurate dyskinetic. The basal is moving because is hyperkinetic, adjacent segment to the dyskinetic or akinetic segment. If you change color again, maybe help you see those differences better. And then again, in apical 2, when you do Simpson, you notice this kinetic area at the mid-inferior. Now let's see in the short axis. Here we have short axis. Each segment, we check each segment together. All of them are moving very well. Both of them belong to one patient. So at the basal, we don't have any problem. But when we go at the mid, at the papillary level, you will notice a little inferoseptal, a little decrease, but the most important part is anteroseptal. Anteroseptal doesn't contract and doesn't become thick at all. It's passive movement by the other part, and the other segment moving and contraction and thickening very well, but anteroseptal segment is akinetic. Here we have another case. This patient, as you notice here again, the basal at the both side has very nice contraction and thickening, wall thickening at the basal, but at the mid we have hypokinetic, and at the apex we have almost akinetic or severe hypokinetic, and at the here at anterolateral, apical anterolateral. Here we have posterior or inferolateral, basal and mid contraction and thickening very well, and basal anteroseptal contraction and thickening very well, but at the mid we don't have contraction and thickening at all. Here the apical 2 and apical 3 of the same patient. Again, here the one that I mentioned at the beginning. We have passive movement of anterior wall, but actually we don't have active movement, contraction. In other words, this part of inferior wall pulling anterior wall this way and bending. So we have passive movement, but we don't have active movement and contraction, and the wall thickening doesn't change at all. So we have anterior wall up to the mid akinetic, antero, apical, and mid anterior. Inferior contraction is very well, thickening is good, and a little hyperkinetic. Here we have basal anterior has thickening and contraction. So we know this one supplied by LAD, left anterior descending coronary artery. So why we have this two segment akinetic, but the basal is normokinetic? As you go back to the blood supply, the basal is overlapping and supplied by, in most of the time, supplied by more than one coronary artery. That is, this one is one of those cases. So at the even the anterior LAD involved in these two, apical and mid, but the basal most probably is supplied by other coronary circumflex, and it doesn't involve is normokinetic. Here in apical 3, as again you will see at the apex and apical segment and mid segment are this one even thinning and dyskinetic. Here is akinetic, here is normokinetic. You will see mid, but in the apical inferolateral or posterior, a little hypokinetic but normokinetic in the basal and the mid posterior. Here we have apical 2 again. Look at the heart moving. Don't be confused about heart moving, as take it as the wall motion. Second, don't forget passive movement of the wall. Don't confuse with active movement and contraction. Here, the anterior wall is contraction and thickening almost very well up to here, but the apex, it doesn't contract very well, and especially inferior at the apical inferior is almost severe hypokinetic or akinetic, and mid inferior is hypokinetic, but basal inferior is normal or even hyperkinetic. Here we have apical 4 again. We have basal and basal here, basal septum or basal inferoseptal, and basal anterolateral, and mid or normal contraction and thickening, but the mid and apical is severe hypokinetic, or even here apical is akinetic. Now I brought this to, I want to mention one things extra. If you look at the septum at the both different cases. Here we have some dyskinesis here at the mid septum. Here we have almost dyskinesis of the all septum. It passing, moving, but doesn't contract. But if you focus and put more attention, you will see two layers of the myocardium, one hyperecho and one hypoecho. Here, hypoecho, and this hypoecho is contracting actually, contracting and become thick, but this part not. Even here, if you notice, we have two parts. One part almost akinetic, and the other part, that the side of the right ventricular, is contracting a little. What is going on? As we know, the left and right ventricular conjugate together during fetal life and forming interventricular septum. And based on the which vessel supply those each part, the function and perfusion and valve motion in those cases can be different. Let's bring this one again. If you notice here, in this case, this part that belongs to the left coronary move a little down during systole, pushing systole, and by contraction of this part that belongs to the right ventricular, this push down, and this part, right ventricular part, move up. So that is the reason you will see these two differences of the septum. Now, let's see this case. This one is apical 2 and apical 4 chamber view of the patient. Again, we go one by one, step by step, and compare each segment together. Anterior, basal, mid, and apical contraction and thickening very well, and apical inferior too, and even the mid inferior, but the basal inferior is almost akinetic. Here we have again anterolateral basal, mid apical, and inferoseptal apical, and mid almost has the normal or even this part hyperkinetic, but basal septal or basal inferoseptal is almost akinetic, or even if you go frame by frame single loop, even is dyskinetic. In this case, if we do straight echo, we can see exactly which point we have abnormal. Here we have blue, even positive strain. Instead of the negative strain, we have positive strain, means we have dyskinesia in the where? In the basal inferoseptal and basal inferior, exactly the same that we saw in those two apical 4 and apical 2 chamber view. And the last tip that I want to mention is contrast for using contrast for evaluation of the valve motion. Whenever two sequence segment cannot be seen very well, the endocardium and myocardium cannot be seen, or the apex, endocardium of apex is not clear, and we will see some hypokinetic or abnormal valve motion in apex. Always we have to use contrast echo. In contrast echo, Beside of the look at the wall thickening and moving endocardium to the inward inside, look at the intracavital cavity, the distance, and see the distance of those spot. Here, for example, if you notice at this spot, the intracavitary space become narrower, which is very obvious, and at this spot it become narrower. But at the apex, not only the myocardium doesn't think is completely akinetic, you see the intracavity at the space at this level even increase during systole. So you know exactly where is your problem, where do you have problem with the wall motion. And the final, whenever you use contrast, don't forget use select left ventricular opacification or LVOT option, or just decrease your mechanical index to below 0.3, below 0.3, not 1.2, and then optimize your image with all those knobs. Here there is a contrast study that used with high or normal mechanical index. We will see a smoke pattern whenever we have low ejection fraction below 25 or 20. We have this smoke pattern, and here is the same with the wrong optimizing image with contrast study. At the last, I hope you like and enjoy this lecture, and if you thought it was useful, please give me a favor and share it. Up to next time, have a wonderful time.